I'm going to talk about biologic tuberoplasty in patients with massive cuff tears. In order to understand that, I want you to pay attention to the acromial-humeral interval. This is what happens in a patient with massive cuff tears. When a deltoid fires, there's a dynamic pull of the humeral head, which makes contact against the acromion. So it's honed in, and you can get a better look at it. And what ends up happening, you get bone-on-bone contact, which we know leads to pain. So essentially what the dermal allograft fixation to the greater tuberosity does is it prevents a bone-to-bone contact because it's acting as an interpositional tissue. Why do I do this, or when do I do this? In patients who have a preserved range of motion above 90 degrees, there should be Hamada 1s and 2s. They should have an intact or repairable upper border subscap, and no chondromalacia, no pseudoparalysis, and if they have an external rotation lag, that's when I do a lower trap transfer. So this is a technique. This is a patient with massive cuff tear. I use the burr on the reverse mode, so not to decorticate the tuberosity, just to remove the soft tissue, just to pepper the blood, get the bleeding. Then I measure the dimension of the tuberosity from the anterior to posterior direction. It's usually 25 millimeters, then medial to lateral, which is about 15 millimeters. Then the posterior anchor is placed first. This is a knotless anchor, which has a repair stitch and a loop stitch, which are retrieved through a 12 millimeter cannula. And if you're starting this out, you can use a cannula divider to keep the sutures separate. So you take the repair stitch and the loop stitch from one anchor and bring it out. Place the second anchor. This is exactly what you would do for a rotator cuff repair, the anchor placement. You take the repair stitch and the loop stitch from the other anchor and bring it out. And again, the cannula divider is keeping them separated. On the back table, the graft is prepared. You cut it to size, or they come in pre-cut sizes now. The medial margin is marked for orientation. Laterally, two luggage tag sutures are placed, so everything's done outside of the body. The graft is brought to the shoulder, placed on a towel, and then the repair stitches are passed through the medial border of the graft, just like that. And the repair stitch is passed through the same loop stitch from the same anchor, essentially converting it into that anchor and creating that locking mechanism. And then essentially by pulling and doing a tension slide technique of the repair stitches, well, first you got to remove the dam, of course. But by pulling on the repair stitches, that reduces and brings the graft into the subacromial space. It always folds like that, like a taco shell, but it's important to have that 12 millimeter cannula so you don't have resistance as the graft is going in. That brings it all the way to the medial border of the tuberosity, essentially like a continuation of the articular surface. The fluffy side goes down laterally. You can use a twist-in or a push-in type anchor to fixate it, and you're just trying to get this graft to lay over the tuberosity, and that's what the final product looks like. The best part of the surgery is the recovery, 3 weeks in a soft sling and internal rotation. After that, you take it off. They can start active and active assist range of motion. The dermal allograft heals to bone in 3 weeks. So the fixation is just intended for the first 3 weeks to allow it to heal. Does it work? The answer is yes. This is 50 patients. We just submitted this to arthroscopy. We're presenting it at ANA in a couple months. Mean age of 65, mean follow-up of 23 months. There was significant improvement in their ASES and SANE scores, significant reduction in their pain scores, and the results were maintained over 2 years. And there were 6 patients in our series that were Hamada 3, and they had similar results. There was no difference between Hamada 1s and 2s. This is a patient of mine who was compensated originally for a year, became uncompensated. I did a reverse on her at 26 months. That's what the histology looks like. There was complete replacement of the dermal allograft by highly organized fibrous tissue, complete integration to underlying bone and articular cartilage, no acute or chronic inflammatory cells, and no blood vessel formation. And the thickness of the graft was maintained with this new fibrous tissue of 3 millimeters, which was a 3 millimeter dermal allograft that was used. So thank you. Under 4 minutes.
Fantastic. Right on time, which I appreciate because I'm not cutting off the course director. Butch Krishnan, let's start with you and we'll go retrograde.
Raffy, this is fantastic. You obviously have to get a 10 because you're the course director, but...
You're coming back next year, Butch.
Yeah, indeed. Hallelujah. So a question about this. We spent a lot of time in Dallas trying to get dead tissue to heal to the glenoid with biologic resurfacing. So we thought we were really pretty good at 2 years, but started to see that by 5 years, things started to disintegrate on the joint. Is this a temporizing operation for you, stepwise in younger patients, or do you really believe that this is a durable operation? Because the one you went back to do a reverse arthroplasty. So really indications are important, and if so, how are you going to, couch this to the patients if it's temporizing?
That's a great question. A lot of questions in there. The reason this patient had a reverse is not because the graft failed. It's because she just developed she had a compensated shoulder that became uncompensated. She became pseudoparalytic. She didn't have pain. She just couldn't lift her arm. That's why she ended up with the reverse. My longest follow-up is 9 years. I have about 5 or 6 patients that are about 4 or 5 years out, and they're still pain-free, still happy with the results. The histology tells me it's not the dermal allograft anymore. It's truly a scaffold that allows the host fibrous tissue to lay down that's going to be durable, and the clinical results are showing that they're lasting over 2 years. So, but it's still a relatively new, young procedure, and of course, longer follow-up will answer those.
Kevin.
Butch got a lot of the questions that I had answered. I really was looking at the age that you really would like to do it. But John Fenlon, years ago, really talked about tuberoplasty in Philadelphia, so I think this is one step beyond. It is a little SCR mania, which makes me nervous with the sutures, so for that, though, I give you an applaud, and so you get a 9.5.
Thank you. Yeah, to me, this has replaced my practice. I don't do SCRs anymore. We have data coming out that the results are identical with SCR versus this. This takes about 15 minutes to do. It's easier than doing an arthroscopic cuff repair for me at this point, so I don't do SCRs anymore.
Question.
Yes, Raffy, is there any role for something like an LTT or something where you're depressing the head? Because I'm concerned about the fact that there's no control of that migration, and yes, you're theoretically rubbing against the acromion with something soft, but they're completely different operations. Is there a role for something other than this?
No, it's not a depressor. It's just a buffer, so there's no bone-to-bone contact. That's all it is.
But would you ever do something like a depressor? Is there an indication in your practice?
I don't think so. I think if in a patient that you're planning, unless they have ER lag, if you're planning on doing LTT, you just cut the end of the Achilles and fix it onto the tuberosity. They'll have exactly identical results than if you had connected it to the lower trap. Not in patients who are having ER lag. Okay, if they have the ER lag maintained, you'll get identical results. I'm convinced of it, but no one's ever going to do that study. So I don't think it's the dynamic head depressor. It's just preventing that bone-to-bone contact, which, if you think about it, that's what the Achilles is doing. It's like an 8-millimeter thick tendon that's preventing bone-to-bone contact.
Raffy, briefly, thanks for teaching us all about this. As you know, we've talked about it. I've combined it with a partial repair, and sometimes I can bring the partial repair tissue over to the medial aspect of the patch. So whether that heals or not, we're going to do follow-up MRIs to see. But I think, you're really onto something, and congratulations.
Thank you so much, Peter. Appreciate it.
Perfect.
Yeah.
Rob Gillespie.
Yeah, obviously, Butch stole a little bit of our thunder of obviously giving you 10s and 9.5s because of your role here. And JT also teed you up by the healing and continuity with the Achilles. But I guess my big question for you is, this is really intriguing, but given what we know about how SCRs did really well in Asia and not as well in the United States, do you think there's a role, or do you think the graft makes a bigger difference? And is there another graft that you might use that's a little bit thicker that may give us better long-term outcomes than you're currently seeing?
Yeah, I think Albert Lind is the best person who studied that. He showed that in his patients with a 3-millimeter allograft, kinematically SCR did not change the kinematics of the shoulder. So after I read his study, that's what ended doing SCRs for me. All the biomechanical data that was done with an 8-millimeter thick TFL. So if you compare that, of course, it's a massive spacer that's preventing humeral head migration. It's not dynamically keeping the head reduced. It's just stuffing the subacromial space, preventing humeral head migration when they're doing the biomechanical
So you think that you could
testing.
get better outcomes with yours if you had a thicker graft?
It hasn't.
so.
It has nothing to do with the thickness. I think if you took the TFL and you just cut it and you fixated TFL to the tuberosity, you would get the same results as an SCR. It's just TFL is a denser tissue. Achilles is a denser tissue. That's why I prefer the dermal graft, because it's so porous and it incorporates so quickly.
We're over time. Eric, one sentence from you.
I love that you've studied this and you've looked at this in terms of your failures early with SCRs and how that's kind of come into a new science almost. I'm a little skeptical of what's going to happen in the long term, but because you're course director, you get an 11.
Thank you.
Love it.
Thank you.